I'm going to turn this over to Dr. Bernstein in just a minute, but I want to give you an introduction, Jen, if you don't mind. So Dr. Jennifer Bernstein and I went to PT school together. And since she has been a practicing physical therapist for over 9 years, close to 10, over 10 now, I think, right?
Mhm.
All of which have been spent at Cincinnati Children's Hospital in Cincinnati, Ohio. Her areas of specialty practice within physical therapy include oncology, hematology, and bone marrow transplant for pediatric, adolescent, and young adult patients. Jennifer received her board certification in oncology in 2020 and has been involved in extensive program development and leadership roles representing the hospital's occupational and physical therapists. She serves as the specialization chair in the oncology section of the APTA, which allows her to actively engage with other passionate members of the organization. She also serves as a mentor in the APTA Oncology Mentorship Program and has greatly enjoyed sharing her knowledge about the world of oncology physical therapy. Most recently, Whole Body Vibration in Oncology Rehabilitation, Perceived Benefits, Barriers, and Clinician Willingness was published in the Rehabilitation Oncology Journal, serving as Jen's second publication. She has enjoyed being featured on the OncoPT podcast and serving as a guest contributor for a MedBridge course about adolescent and young adult oncology. And we are so happy to have you here, Jen. So thank you very much for coming.
I'm so excited. I feel like I could talk about this topic for days. So the hardest part about this for me is going to be keeping it within our scheduled time. So thank you guys for coming and being willing to listen and learn all about oncology in the acute care setting, specifically with a focus on peds. So I'm going to share my screen. Let's hope we can get it the first time. All right. So welcome to our discussion again about oncology and acute care pediatrics. I have nothing to disclose, no conflicts of interest related to this presentation or the content. Sarah did such a wonderful job giving me an introduction, but I just wanted to throw up a couple really cool things that I've been able to accomplish over the last 10 years, not so much as a brag, but because these were things I didn't even think were possible. And so I hoped that it would kind of inspire you guys to put yourself out there, dream big, and know that you can do anything that you set your mind to. So some things that are really special to me are my board certification in oncology. I actually sat for this exam in 2020. I sat for my test on March 12th and the world shut down on March 16th. So there was a lot up in the air in the beginning, but and a little bit of a slow start to what being a specialist was going to mean for me. But one of the best things that it's brought me is the ability to sit down and talk to students and therapists like you guys. So I'm excited to be here and thank you again for having me. Some of the things we're going to talk about today, I really want you guys to take away and demonstrate an understanding of some of the common pediatric oncologic diagnoses. I want to discuss treatment options and their impact on growth, development, and function. We're going to talk and identify precautions, indications, and contraindications to be considered when working with individuals throughout the cancer continuum. We're going to acknowledge the diversity, complexity, and variability involved in a cancer diagnosis at various stages of life. And we're going to establish an understanding of the role of physical therapy throughout the continuum of care for patients undergoing treatment for cancer in various practice settings. So, cancer, it is this infamous C word. It makes people really, really nervous. And one of the things that I hear all the time, especially from students or new therapists, is I'm never going to see a patient with cancer in my practice setting. So it's not something I have to worry about. But I'm hoping that as we go through this presentation today, you're going to see that not only are you going to see a patient that has a cancer diagnosis, probably at some point in your career, regardless of where you are, but you may even be the ones that pick up on some red flags that refer this patient back to a doctor to get a diagnosis. So it's really important to be comfortable with this cancer word. So what is cancer? There we go. We're going to talk about it. We have to understand it a little bit. So cancer, breaking it down, is a class of diseases characterized by uncontrolled cell growth. And when these cells divide uncontrollably, they can interfere with normal body systems and function. One of the things that I always like to throw in is there are things that happen within our bodies just at random. There's a mutation in these cells, or they're dividing uncontrollably. Things are happening, and it's just kind of random. One of the things that's important to also remember with cancer is that there can be a genetic tie to a diagnosis. So, most commonly, I think when we think about a genetic component, we think about BRCA with breast cancer, but this can also be common in pediatrics. So, keep that in mind. As we talk about things throughout this presentation, I may refer back to this because sometimes it changes the approach to treatment. If something is genetically modified, we may have to do something a little bit more aggressive. There are two main types of cancer that we'll talk about today. We have the hematologic, which are blood cancers, which sometimes are also referred to as liquid cancers. One thing you'll learn also throughout this presentation is there's a million different names for the same thing. So bear with me. But blood cancers, hematologic cancers, liquid cancers, they're all referring to the origin of the blood. And then you also have solid tumor cancers. I want to talk briefly about cancer throughout the lifespan. So you have your pediatrics, which are ages birth to 14. You have adolescent and young adult, which is ages 15 to 39. And then you have adults, which is ages 40 plus. And the reason that I wanted to kind of bring this up was because, especially for me, before I got into this world of oncology, peds oncology, a lot of the social media and promoting that I saw out in the world was for these typical adult cancers. So things like breast cancer, lung cancer. I think about all of the like non-smoking commercials that were big in my youth. Even now, where they have, a patient talking about their cancer journey from smoking. You see mammography trucks out rolling around the neighborhood. And that's where a lot of the research and funding is focused, is these adult cancers. But the truth of the matter is there's also two other completely different categories where the cancers are a little bit different. You're not necessarily going to see your breast and lung and thyroid cancers in your pediatric patients. So it's important to know that there are different cancers throughout the lifespan. We're going to talk and focus mostly on the pediatric population today, but what's also important to remember is that our pediatric patients turn into our adolescent and young adults, and those patients turn into our adults. So again, it kind of follows that lifespan, and it's important to see and remember what can happen in each category. For my program, where I work at Cincinnati Children's Hospital, even though we're a pediatric institution, we actually see both pediatric and adolescent and young adult patients. So I have patients on my caseload that are 39 years old, which seems a little bit odd in a pediatric institution. But because of the overlap between the pediatric and the AYA population in terms of diagnosis, we treat these patients just the same. They may just need different amounts of drugs or different amounts of treatment to kind of help them. So I wanted you guys to kind of have an idea of how these categories are broken up. In terms of pediatric cancer, about 9,910 children in the United States under the age of 15 will be diagnosed with cancer in 2023, which is a lot. It doesn't seem like it compared to like how many people there are in the United States, but it's quite a bit. And even though our focus today is going to be mostly on the pediatric population in the acute care setting, I want you to think about, as we talk, that once our patients leave the hospital, it doesn't mean their cancer journey is over. It's really important to understand that because the survival rate is going up for this patient population, which is incredible and everything we could hope for, it does lead to you guys as clinicians and future clinicians being responsible for a patient with cancer somewhere along their continuum. The other part of the puzzle is that with this longer survival comes an increase in chronic long-term toxicities, which impacts function and quality of life. So it's really important for you guys to consider not only the immediate survival, but also long-term functional recovery. We're going to talk very briefly about common pediatric cancers. I could probably do a presentation on each of these. That's 2 or so hours, but we only have roughly 45 minutes for actual lecture, and then we'll do some discussion. So I just want you to be familiar with these names. The biggest thing I want you to take away from this slide is that each of these diagnoses have a different impact on the body, but they will lead to likely an impairment in all 11 body systems based on not only the disease burden, but the treatment burden. So we'll run through them quickly. And again, if you guys have any questions about anything specific or you want to know more information, jot it down so we can come back to it at the end when we have time for questions. But leukemia, it's probably one of the biggest diagnoses I see in a pediatric hospital. Leukemia is a very broad term for cancers of the blood cells. It can be acute or chronic. And like you'll see as we go through some of these names, most cancers are named for the cell that they start in. So leukemia, you usually hear about AML or ALL, your acute myeloid leukemia, your acute lymphoid leukemia, and those are differentiated based on the cells that it starts in. Lymphoma. Lymphoma begins in the cells of the lymph system. So typically, and probably what you guys have heard most often, are Hodgkin's lymphoma and non-Hodgkin's lymphoma. Neuroblastoma. I'm sorry, I skipped over 2 big important ones, brain and spinal cord tumors. So they originate in the brain and spinal cord. These are considered kind of our neuro-onc diagnoses. So with this patient population, we expect to see a lot of neurological changes happening. Sometimes it starts off with a loss of balance. Sometimes we're getting some numbness and tingling. Sometimes we're seeing some eye divergence. Sometimes we're seeing some paralysis, some sensation changes. So very typical neuro symptoms. Bone cancer. Usually we see osteosarcoma or Ewing sarcoma. And again, these are of the bones in our body. Neuroblastoma. Neuroblastoma is a tricky one because a lot of times when people first hear about neuroblastoma, because of the words, we think about neuro. So people think brain. Neuroblastoma actually forms in the neuroblasts, which are immature nerve tissues, but it's actually most common in the adrenal glands. But it can form anywhere where these neuroblasts are located. So you can get it in the neck, chest, spinal cord, but most of my patients that have a diagnosis of neuroblastoma come in with some type of large growth in their abdomen. And that's a tricky one. And keep this one in mind because we're going to talk about it a little bit more later in a case study. Wilms tumor. So a Wilms tumor is a tumor in the kidney. So it can kind of be called kidney cancer to some extent. There are a little bit of the difference when you talk about an adult kidney cancer versus an actual Wilms tumor. A Wilms tumor is very, very rare. And what actually causes it is a change in the DNA of the cells as it's dividing. So you'll see that there's often, it's called like a genetic component to this, but it's not the genetic component where there's a mutation that's passed down from parent to child. It's as these cells are dividing that we're seeing a change in the cell DNA, which leads to a Wilms tumor. Rhabdomyosarcoma, which I like to call rhabdo for short because it's a lot easier. A sarcoma is cancer of the soft tissue. So when we add rhabdo to the beginning of that word and myo, we're looking at this cancer originating in muscles, tendons, cartilage, or bone. And then we have retinoblastoma. So that's where these cancer cells form in the tissues of the retina. And this one, I think some people have heard of before. A lot of people first start to notice that something is wrong with their child when they are taking a photo of them. And you know I'm older because I just went like this to take a photo. I feel like now everybody just does that with their phone. The kids at the hospital remind me of that all the time. They also talk on the phone, play phones like this. So it makes me feel very old. But with retino, a lot of times parents will say, that's weird. Like there's no red eye in this eye, but there's one on this eye. And there's like kind of like a white, milky substance in the eye. Maybe it was just how the picture developed. And then they start to see multiple changes. So sometimes those pictures are like that first warning sign and they don't even realize. So, like I said, I know that that was a super brief overview, but bear with me. There's a lot we could talk about, and I want to make sure we can touch on a million different things tonight. Early warning signs. So, one of the first times I gave a lecture and I talked about early warning signs, I had everybody email me and be like, oh my God, do I need to go to the doctor? I have so many of these things. I'm spiraling. So, this is not to freak you out at all, but it is important to know about some of the early warning signs of cancer. I want you guys to think about these as disease-related impairments. And I want you guys to think of it that way because there's different disease-related impairments and treatment-related impairments. And you'll see as we talk today why I want you to have that differentiated in your mind. So for me as an acute care therapist, I'm not necessarily going to have to be a detective for an actual diagnosis. Most of my patients that I'm seeing are coming into the hospital because they had symptoms that led them to go see a doctor, and that led to further testing, further investigation, and now we have a formal diagnosis. However, depending on where you are, whether it's with pediatrics, your AYA population, adults, your inpatient, your outpatient, your sports ortho, you may be the first person that comes in contact with this patient. And as you start to treat and ask questions and prompt, there might be something that goes off in your head. Not this isn't adding up, and I need to refer back for ongoing assessment. So some things to look for when you're asking for a patient history. And to be fair, I know that not patients aren't always the best historians, or they're not always answering truthfully. But you may even notice some of these things as you're working with patients in your setting. So unexplained weight loss. A lot of times for kids, it's a change in their appetite. They're not feeling hungry. I don't know how many of you guys have kids on this call or have nieces, nephews, things like that. But kids, especially when they're growing, they can eat. And so a lot of parents come in and they say, it was really weird. Like my kid usually comes home from school and it's ravenous, shoving food in their mouth, can't get enough. And now they're denying a snack. And that just seems really odd. Some patients are reporting belly pain, nausea, vomiting, even trouble swallowing. Sometimes the trouble swallowing is a mechanism of the disease itself, and sometimes it's related to that nausea and vomiting, and they just don't want to have that feeling if they eat. Some patients are coming in with a massive weight loss over a couple of months, and that is always a red flag to check what's happening. Fatigue. I think all of us can probably say, like, this is the number one symptom in my life. But this is excessive fatigue that does not get better with rest. Doing daily functional activities that are usually, like part of a normal routine are exhausting. These patients, especially in pediatrics, they may not be able to make it through the school day without going to the school nurse and asking to lay down. They may not want to play sports or play their video games because they're just too tired. I just had a patient whose family said the final straw was they had a birthday party for this patient's sister, and there was a bounce house, and all the patient had talked about for weeks leading up to this was this bounce house. And they started seeing some weird behavior a couple weeks before, but the day of the party, the patient had literally said, I don't want to do the bounce house. I just want to go inside and sleep. So it was at that point that they were like, something's up. Fever, mostly at night with some of these oncology diagnoses. And there's usually no other symptoms of infection. So you're not seeing it associated with a runny nose or, any of these other signs of infection that we see. I know that's hard with kids because especially during the school year, they're gross. They're covered in snot. They're always getting sick. But these are really these unexplained fevers and night sweats. Night sweats is a big one, and another kind of red flag that should go off in your head. Pain, new pain, unknown reason, doesn't go away. It gets worse. Kids who are complaining of their legs hurting, but they haven't really done much. A lot of times I hear parents say, well, my kid had leg pain and I took them to the pediatrician and everything else seemed fine. And they just figured it was growing pains, which it could be. But this pain doesn't go away. It doesn't get better. Sometimes our patients are complaining of headaches or painful urination. So again, once you're ruling out all of those other reasons that these things could be happening, might warrant further infection. And honestly, changes. And I know that that's a really big category, but sometimes we see changes because our body is trying to tell us something is happening. So skin changes. A lot of our patients, when they're first diagnosed with leukemia, have something called petechiae, and they're these little red dots that appear on the skin. And that's because our blood values tend to be a little bit lower as our body is starting to fight this leukemia and the leukemia is multiplying. So skin changes is a big one. A cough or hoarseness in their voice. Unusual bleeding or bruising. This is another really big one. Multiple nosebleeds or bruising that is just excessive. One of the biggest bruises that sticks out in my mind is I had a patient who was a soccer player and she was a goalie. So she's diving, she's rolling on the ground. And when I tell you the imprint of the soccer ball was on her thigh, completely in a bruise, but you could see every shape, every line. And that was the tip off for her. Like, I shouldn't get a bruise like that from diving and catching a ball. Changes in bowel or bladder habits. This should be a big red flag for pretty much anything, but depending on where this tumor or cancer is located, this could be a really, really big one. Vision or hearing changes, mouth sores or bleeding, or even swelling or lumps in different areas of the body. So it is important to understand for you guys as clinicians why, if a patient is reporting these things, to keep it in the back of your mind as you're making your differential diagnosis if you're not already in a cancer setting. We're going to jump into cancer treatment and side effects. So I could, like I said, talk about, I feel like I'll say this the entire presentation. I could probably talk about each of these things forever, but we're going to do a quick run through. So things that you guys have probably heard about: chemotherapy, radiation. Something that's a little bit newer on the map is called proton therapy. And it's really a way to take radiation and target it into a more specific area. And why that's important, we'll talk about in a little bit. Immunotherapy. So immunotherapy is incredible. Basically, what's happening through research and kind of learning about these diseases is scientists are able to go in and say, there's a gene on this type of leukemia cell. Let's say it's CD33. And we've figured out the kind of drug we need to use to target CD33. And so we're going to make it and we're going to give it to you. And it's going to go into your body and there's going to be a magnet, basically, between the drug and the gene, and we're going to blow it up. So that is so cool. And the first time I learned about immunotherapy, I was like, why haven't we cured cancer? Like, this seems very simple. And in the conversation I was having with one of the oncologists, he was like, that's so cute. Like, yes, in an ideal world, like, we would cure cancer this way. However, there are so many genes, so many variations, and just so many things we don't know yet. So this is super promising, but we only have the ability to find so many of these connections at this point in time. Surgery. Surgery can be, and we'll talk about it in a little while. It can be a treatment for cancer, but it can also be used for a lot of different things. And then we have our stem cell transplants. So you will probably hear me talk about a stem cell transplant as a bone marrow transplant. That's the language that we use in my setting. So if you hear me say bone marrow transplant, BMT, I am talking about a hematopoietic stem cell transplant. Chemotherapy and radiation. So the things that are bolded and italicized on these slides are the common symptoms between both. But you can see just from looking at this slide, from receiving these treatments, what can happen to a patient's body. So we're giving them these drugs that essentially are going to help them help their disease, but we are also annihilating their bodies. The really, really tricky thing with chemotherapy and radiation is that they're what we call non-specific cytotoxic treatments, meaning they target those unhealthy cells, but they are also targeting our healthy cells in our body. So we see these massive changes in side effects from them. And chemotherapy and radiation is what is largely responsible for those long-term health and functional consequences, including exercise intolerance, which, of course, as therapists, is important for us. So when we're talking about things like myelosuppression, neutropenia, thrombocytopenia, we're looking for changes in their blood values, their platelet thresholds, their immune system counts. We're going to see them be nauseous and vomiting, which leads to them not wanting to eat, which leads to them not getting protein and not getting carbs. So we're seeing a decrease in muscle mass and their ability to build muscle, and they just don't have a lot of energy. We're seeing a lot of organ toxicity and body system toxicity. So we're seeing it nephrotoxicity, ototoxicity. So many of my patients that receive certain types of chemotherapy end up with hearing loss, which you can imagine is difficult, especially as a child. One, tolerating hearing aids, being in school and looking different and having to wear hearing aids and having accommodations. That's a big deal. Neurotoxicity, especially for my little patients. This can be a big one because it can really impact their ability to grow and function over time. Cardiac toxicity, that's a big one. We'll see cardiac and pulmonary toxicity. Mucositis. Mucositis is something that happens in our patients' mouths. It's really, really uncomfortable. And essentially what's happening is as their immune system counts are lowering because of the chemotherapy, they're starting to get these sores in their mouth. If you can imagine like the biggest, most uncomfortable canker sore you've ever had and then multiply it by 100, that's what's happening in their mouth. The other thing with mucositis is that it's happening in those mucous membranes. So unfortunately, it's not only in the mouth, but it can go all the way down your digestive tract and even into like the areas of your anus. So going to the bathroom can be incredibly uncomfortable. Pain, whether it's in your joints, your bones, just everywhere, achy. Hair loss. Hair loss is a big one. A lot of our patients are losing all of their hair. Some are losing hair that's in a more local area to where they're getting radiation, but mostly we're seeing that total global hair loss. We're seeing peripheral neuropathy, which is a huge one. Chemotherapy can really block the channels that our brain and our nerves are using to talk and communicate. So peripheral neuropathy is a really, really big thing we see. Our patients report numbness and tingling in their fingers and their toes. So some of the early warning signs we see, and this is where kind of being a detective is important, especially in pediatrics, because sometimes our patients can't describe adequately what they're feeling, especially if they're younger. So you may start to see like a patient that's super, super independent with things normally, not wanting to open bottles or help get themselves dressed. They don't want to like eat food with their hands. They are not wanting to wear shoes, or all of a sudden they're toe walking, or they're just refusing to walk in general. So these are kind of some cues that we can observe for patients that may not be able to vocalize and tell us that something is happening. Fatigue. Fatigue is a big one. This can be related to disease and it can also be related to treatment. Weight loss. a big one. Not only weight loss, but muscle loss. There's a statistic out there that's like for every day you're in the hospital, you lose 1.5% of your muscle mass. And especially for some of my patients with a new diagnosis of leukemia, they are in the inpatient setting for 30 days straight. So you can imagine if we weren't doing some type of intervention and they were just kind of lounging in bed, what that could do to them and how it could impact their function. We're also going to see some of those skin changes. So we're going to see some hyperpigmentation, some irritation, even some fibrosis. And then, of course, some of these treatments can cause infertility and urinary and bladder problems. So our stem cell transplants. So our stem cell transplants are a cure for a lot of the oncology diagnoses that we talked about previously. Sometimes we know that this is going to be part of a patient's treatment regimen if they have that genetic anomaly that we find when we do further testing, and that's what's led to their cancer diagnosis. We know that we are not going to be able to totally cure their disease unless we give them medications that completely annihilate their bone marrow and give them new bone marrow. With regular oncology treatment, with chemotherapy, with radiation, what we're doing is we're suppressing their immune system and we're trying to get rid of those yucky cells and hope that their own immune system starts growing those regular cells again. But with a stem cell transplant, or a bone marrow transplant, we are literally taking away an immune system that they had and giving them an entirely new one. So something that is a favorite fact for a lot of my patients is that if you commit a crime and they test for the DNA of who was at the crime scene, it's going to come up as your donor's cells, not yours. So all the kids are like, ooh, I can rob a bank and do crazy stuff. I don't encourage that, but it is kind of cool. So some of the things that come along with these bone marrow transplants are infections, viruses. You have to remember that all across the board for these oncology patients, we are suppressing their immune system. So they are susceptible to just a common cold can be a really big deal for them. Things that live inside of all of us, like C. diff, Epstein-Barr virus, cytomegalovirus, virus, we have all of those, but our immune system is super healthy and it's not a big problem. But when you take away that immune system, it gives these kind of viruses a place to play, and it can really cause some big problems for our patients in the long run. Graft versus host disease is another really, really big topic when we use stem cell transplants as treatment methods. So graft versus host disease is something that I relate to. I think a lot of people can make that connection when you give somebody a new organ. So somebody donates a kidney. You hear a lot of times about rejection or failure to, graft. And that's the same thing that can happen with cells, with your red blood cells, white blood cells, platelets, especially if they're from a donor. So there's two different types of transplants that you can get or you can have. So autologous, which I like to think of like auto yourself, and allogenic is a donor. So if you're getting your own cells, you don't have to worry as much about graft versus host disease because your body knows your own cells. But if you get them from a donor, they're foreign. So we're putting a foreign body into your body. There's different types of donors that you can have. So your donor could be your sibling or your parent, which in case you share DNA, so the risk of extreme graft versus host disease is a little bit less. Or it can be from an unrelated donor. That's why we have bone marrow registries, which I highly encourage you all to join if you haven't already. Just a little swap, nice and easy, no big deal, and you could save someone's life. But anyway, so if you have this unrelated donor, we're giving you cells from somebody completely different. Yes, they have a similar makeup to you, which is how they've done that matching, but it's still someone new. Graft versus host disease is a tricky thing because you want to see a little bit of it so that you know that the body is recognizing that there's something happening, but we don't want it to become powerful and take over. Graft versus host disease can be of the gut, it can be of the skin, it can be of the eyes, you name it. And it can be really, really painful for patients and ultimately something that can really impact the outcome of their treatment, and even lead to death. We also see a lot of the same things that we do with chemo and radiation: fatigue, nausea, vomiting, hair loss, mouth sores, and a lot of that myelosuppression where we're decreasing a lot of the counts in our bodies. Surgery. So surgery itself can be curative, which is awesome. We can go in and we can remove a tumor. It could be preventative. It could be diagnostic. We might have to get in there to see what's happening. It might help us just understand where we are in the staging process. We may be able to go in and start to debulk that tumor and kind of help decrease the burden of what's happening in our body. Sometimes surgery can be palliative. So we know that there may not be a cure, but we have the ability to make a patient more comfortable by doing some type of surgery. And the same thing, it can be supportive in their care process or restorative. I threw a little video in here of something called a rotation plasty. I hope this works. This is literally one of the coolest surgeries I have ever seen, and is becoming way more popular now than it ever has. So hopefully this is going to take us to the internet quickly, and then we'll pop back into the slideshow.
A rotationplasty is a surgical procedure that provides an excellent option for patients with tumors in or near the knee joint. It is best applied in children who are still growing. During this procedure, the surgeon removes the affected portion of bone along with the knee joint. The major artery, vein, and nerve leading to the foot are saved. The lower portion of the leg is rotated 180 degrees counterclockwise and then attached to the upper portion of the leg. The ankle is now on the same plane as the former knee, with the foot and toes pointing backward and the heel facing forward. Because of the rotation, the ankle bends in the same direction as the knee. The surgeon will take into account the age of the child and their growth potential. Initially, the surgically modified knee center will be lower than the unaffected knee. As the child grows and bones lengthen, the knee centers will match. In 3 to 6 months after the bones have healed, the patient can be fitted for a prosthesis. The patient's foot fits inside the socket of the prosthesis, and the ankle functions as the knee joint. In time, the patient will develop greater control, function, and mobility. Most patients are able to walk unassisted and return to their regular activities, including playing sports.
I just think it's so cool. I will say, I'm going to stop sharing again so we can make sure that this comes back up the right way.
Most people have no clue that
Guys, back in.
Got it.
Perfect. And you can see the full screen.
Yeah.
We did it. So I will say one of the really tricky things with these rotation plasties for patients who are continuing to get chemotherapy, we know that chemotherapy can delay healing. It can impair skin integrity. It can lead to redness, itching, same thing with radiation and these other treatments that they're getting. So it can be really frustrating for patients who have these big surgeries because things don't necessarily move as fast in the real world as that video may make it seem, because sometimes things are just taking longer. Other treatments to consider when you're working with this patient population are steroids. Steroids is a big one for me. I see a lot of my patients experience muscle wasting, bone changes, weight gain, which not only can affect their physical being, but also can really impact their mental health. Immunosuppressants, they have to be isolated. They can't go to school. They have to be, in a room in the hospital. They may not be allowed out in the hallway if their immune system is too low. Their homes become like literally the place that they can be. They're not going to go to the mall or the zoo where there's a million people. Things like benzodiazepines. So if our patients are getting these, they're drowsy, they're dizzy. It makes getting up and moving hard. Same thing with those anti-nausea meds. They're important for our patients, but they can become drowsy. We can see weakness, lightheadedness, and then you got to love those narcotics. You got to be careful with this patient population because sometimes they ask for narcotics just to sleep through their hospital admission. So it can be really tricky. And your nurses, your doctors, your medical teams will do a really, really great job coordinating with you and trying to give them enough pain meds that they can successfully participate, but hopefully not too many where they're just kind of snowed because that can cause a problem, understandably. Activity considerations. So some things to think about when we're working with patients. So like we talked about earlier, chemotherapy and radiation are both these non-specific cytotoxic treatments. So they target those unhealthy cells, but also in turn, our healthy cells are impacted. So they're largely responsible for long-term health and functional consequences, like we said, including activity and exercise intolerance. So this can manifest in your patients as impaired aerobic and anaerobic fitness, decreased muscle strength, impaired neuromuscular coordination, balance, and flexibility. Things that as therapists, we really need to take into consideration are what is happening to their blood counts. Now, when we talk about hemoglobin, it's the predominant oxygen carrying protein in red blood cells. When you have a low hemoglobin, you have anemia. So that means the cells in our body are not getting enough oxygen. So one of the things that I really want to highlight here is every institution is a little bit different. So if you are working with patients that are anemic, please make sure you're coordinating with the patient's medical team so that you can know the right thing to do with and for these patients. Things to be aware of is exercising in an individual that has anemia can place increased oxygen demands on the body, which then causes your heart rate to increase. So your intensity, your mode, and your duration of activity may need to be altered a little bit. If the patient is clinically symptomatic, so they're reporting that they're short of breath, they're lightheaded, they're having chest pain, you need to adjust your program or stop. I will say the reason that I really want you guys to check with your medical team for guidance about hemoglobin thresholds is because sometimes our patients function beautifully at the level that isn't normal. So a lot of times when we look at guidelines, like a hemoglobin below 8, it's like, don't exercise. And I go into a room and a patient's hemoglobin is 6.5 and they are bouncing off the walls, full of energy and doing great. So that is why it's important to not only have these kind of numbers and ranges in mind that your institution puts forward, but also look at the patient and how they're presenting. Take that symptomatic approach as well. The other thing to consider are platelets. Platelets are the primary blood components that initiate the clotting process. So if you have low platelets, you have thrombocytopenia. So again, encourage you to check with your medical team, but there's a high risk for vascular trauma and bleeding as a result of activity. So what are we doing when we're doing strengthening? We're making these tiny tears in muscles and that's how they're growing. We can't see that as it's happening. So if we are providing a patient that has a very low platelet count with high resisted exercises, so probably our AYA, those adolescent and young adult patients where we're giving them free weights or TheraBand, we could put them at an increased risk for bleeding. So make sure that you're taking their platelet count into effect and that you may have to adjust the mode of exercise or activity. So things like stretching and resistance may have to be put on hold, but something like a really gentle walking program might be appropriate. The other thing to consider are white blood cells. So white blood cells are the cells of your immune system that defend the body against infection. So abnormally low volume of neutrophils is neutropenia. A lot of times we refer to that as ANC, your absolute neutrophil count. For patients at my hospital, if they're on the oncology side of things, we can see them if they have an ANC of 0, which seems a little scary, but we have to take precaution. So if we are taking them out of their room and up to a gym, they have to wear a mask because we really want to make sure that they're not exposed to anything. We have insanely strict cleaning policies for toys, gym spaces, things like that. And all of our patients that are immunocompromised are seen in an individual gym. There's nobody else in there at the time that they're there. And the same goes for our outpatient setting, which can be a little bit tricky, but we schedule these patients at clinics that have private rooms or at times of a lower census. So they may be like the first patient of the day, the last patient of the day, or at like lunchtime when kids aren't really in there. We really want to do this because we don't want to expose them to more germs, because that can lead to infection, fevers, things like that, and prolong their hospital stay. So making sure that things are cleaned thoroughly and that they're a little bit more isolated is always really important. So the summary of your precautions and considerations, always check with the medical team regarding counts and interventions. Really try to take that system-based approach because you don't want to count out a patient just because of their lab values. They may be presenting perfectly fine. And again, lab values should not be the sole determinant of whether or not to initiate exercise or activity. In terms of cancer diagnosis, treatment and beyond, we're going to talk a little bit here, especially about pediatrics. We've talked a lot about the physical changes that happen and the activity limitations that we have to take into consideration, but we haven't really talked yet about the psychosocial and mental health components of treatment and how it kind of follows these patients into their teenage years and adulthood. So you think about these pediatric patients, and these, we know are anywhere from birth to 14. So you think about what's happening when they have a cancer diagnosis. They're not allowed to go to school sometimes, depending on where they are in treatment. So all of their peers, their siblings are getting to do something normal and they are not. That's really hard for them. It makes them feel different. They have limited interaction with same age peers. So I genuinely, especially during the COVID times where it was even more isolating for these patients, my patients genuinely didn't know how to play. And that's hard to teach. Because even at home with their siblings who were doing a modified school program or going out in the neighborhood and playing, like they could not interact with their sibling, or they were in the hospital for a prolonged time because there was no way to avoid that overlap. We see behavioral changes. This is something that is huge, and I talk to parents about a lot. Not only do we see these behavioral changes because of steroids, but sometimes for these patients, they have literally zero control over anything that's happening to them. All decisions are being made for them by a medical team, essentially strangers. And the only thing that they have control of is their behavior. So I see a lot of times patients come in and all of a sudden they're hitting their parents, and they've never hit their parents before. They are having accidents. They're regressing in terms of potty training. And this is so emotional for parents because they're dealing with a diagnosis and then they're seeing their child change. So this is a big one. What I always do is encourage parents and let them know that this is normal. Parents are always apologetic to us as therapists, right? They're like, I'm so sorry my kid said you were ugly or like threw a toy at you. They're mortified, and it's honestly just part of the job. And sometimes you have to let it happen. Obviously, there are things that you can't let fly, but it's important to understand that this is how they're coping. Developmental delays, stunted growth, these are big. Our patients, again, are isolated, so they're not seeing their same age peers. This is something that was really, really challenging for us as therapists during COVID because we have masks on, and so much of our babies are looking at our facial expressions, watching our mouths, and that's how they're learning. And we've taken that away from them completely. So that was really interesting to watch. I talked a little bit about toilet regression, not only from a behavioral perspective, but we are also throwing fluids at these patients to help make sure that their other organs continue to function properly. So a lot of our patients have accidents in the middle of the night, not only pediatrics, but even our AYA population, and that is mortifying to them. Sometimes we're ending up getting patients bedside commodes, especially for nighttime, because they're hooked up to an IV pole and monitors, and that's the fastest way that they can get to the bathroom. Anxiety and depression, post-traumatic stress disorder, my goodness, that speaks for itself. I think about the things that my patients go through, and I'm an adult, and it stresses me out. And these kids handle it so beautifully and with grace, but it's also really scary. I had a patient who went through treatment, an oncology treatment for leukemia as a 3-year-old, relapsed and went through treatment again as a 5-year-old. And because he relapsed in such a brief amount of time, he had a bone marrow transplant and really did well through all of those. And went back to school, was seemingly doing normal kid things, was on the playground and was playing kickball and broke his femur and had to come in, had to have surgery, the whole shebang. Now, did he break his femur because he was doing something crazy and it would have happened anyway? Or did he break his femur because he had low bone density and his muscles weren't super strong because of everything he's gone through? We'll never know. Chicken before the egg, who knows? But what was alarming for me is he came into the hospital for this surgery and his first thought was, am I going to die? And that is because of everything that he had been through previously. All of those emotions, all of those feelings came rushing back to him being in that hospital environment. So keeping in mind that being back in a hospital or a clinic or using some of these big cancer words can be scary for patients. Body image, self-esteem. A lot of our patients were seeing weight gain, scars, hair loss. We're giving them AFOs or walkers and crutches, and they feel different because they look different. They look different than their peers. And that can be really, really hard for patients. And truly, especially for our AYA patients, a lot of them are supposed to be teenagers or going to college, or they've started families and have jobs and homes of their own. And I think about if when I was like 15 or 16, if I had to share a hospital room with my parents, I don't know what I would have done because there would have been a lot of yelling and fighting. So you think about the environment they're in. You think about the fact that their friends are getting to play sports and experiencing homecoming and prom. And we can do stuff like that at the hospital, but it's not the same. So you think about these things that are happening to a patient that they have no control over and how much it can affect their entire lives. Something that's not talked about very often is the financial burden and financial toxicity of cancer treatment. You think about our patients who are in their 20s, they have a home, they have a family, and now they can't work. So not only are they paying for cancer treatments, you hope they have insurance, but they can't provide for their families because they have to be away from their job. So they start to be fearful, like, can I get food on the table? Am I going to have to foreclose my home? So these are big, big problems. One of the things that I want to talk about very briefly as we get closer to the end of our presentation are the Dietz classifications of cancer rehabilitation. And what I want you to take away from this is cancer care and cancer rehab is different than any other type of therapy that you will do. And the reason being, a lot of our patients are coming in, like we talked about, with those disease-related impairments. But when you do that first assessment, they don't necessarily have a ton of functional impairments yet. And a lot of us as therapists are like, all right, like the way our brain thinks, no functional impairments, well then I probably don't have to treat them. They don't need therapy. There's no acute needs. But we know that as soon as we start treatment, we're going to start to see impairments. So the Dietz classifications talk about 4 different types of rehab approaches: a preventative approach, a restorative approach, a supportive approach, and a palliative approach. And I want you guys to just take away that we as therapists have a role in each of these areas. So whether it's to help get a patient back to doing what they're doing, or to help maximize their life at the end, to help their parents, to decrease that caregiver burden, it's all really important. I'm really excited for this part. I want to tell you guys a little bit about what my day looks like on the inpatient setting, and then we'll talk about cases, and then I'll throw it to you guys for any questions. So a typical day on an acute care pediatric oncology unit, and I say typical because there's no typical day. And that's the thing with oncology care. Things can change in an instant. I can't tell you how many times I have my whole day planned out, and all of a sudden a patient needs platelets, they spike a fever, they need to go down for a stat ultrasound. So you have to be real good on your feet. One of the things that I love about being in acute care pediatrics is that I get to be creative. I am definitely not someone like I know ortho is like the big hot thing. People love it. They thrive on it. I have a hard time with ortho because I feel like I have to follow a protocol and I like to do my own thing. I don't like the rules. So this gives me a really fun, unique opportunity to target my strengths as somebody that's creative. So one of the first things I do in the morning is I do a chart review. So I'm looking at lab values. I'm looking at my patient's platelets, at their hemoglobin, what their ANC is, so I know where and when I can take them places. For our patients, if they've had a fever within 24 hours, they cannot leave the room and they have to be fever free for a full 24 hours before they can. I'm coordinating with my OT partner, not necessarily co-treating, but we're collaborating. Some of our patients have a limited time where they can come off of monitors or be unhooked from their IV pole. So we want to maximize that time. We want to book treatment spaces around their busy days. And it's a great way to really ensure to some degree that your day goes successfully. I contact nurses and the medical team pretty much every morning. I want to say, hey, my plan is to take Bob at 1 o'clock. Anything that you can think of that might interfere with that. Sometimes they tell me no and it works. And sometimes they're like, orders changed. 1 o'clock isn't going to work. And that's usually at 12:55. So again, being flexible, thinking on your toes. I also ask my nurses a lot to communicate with families when we're coming, so it's not a surprise and they're ready. And my goal every day is to get these patients up and moving and having fun. So getting up and moving and exercises in a pediatric oncology unit looks a little bit different than maybe in an outpatient unit or an outpatient setting where they're coming in, you're doing a warm up, you're giving them exercises, you might do some hands-on manipulation, stretching, massage, things like that, and they're doing some type of cool down. So for me, I'm really looking at what does my patient need? How can I target their interests? So I like to do some different out of the box things like exercise Uno. So like Uno's their favorite game. Cool. Let's play Uno for therapy. But first we're going to do it standing up and we're going to pick a number and a color and a sign and we're going to assign exercises to it. And every time that comes up, we're going to do that exercise. Things like that to get them motivated and engaged. We have a kitchen that we can take our patients to. And I know a lot of people are like, but cooking, like, isn't that an OT task? I'm not necessarily looking at how they're doing the actual activity of cooking, but can they squat to get a pot out of a cabinet? Can they maintain, do they have that activity tolerance to stand at the stove and cook? Can they walk to and from the kitchen? So being creative, the same thing with showering. I know that, a lot of people are like shower equals OT. But for me, sometimes showering is, do they have the endurance to stand in the shower? Can they bend down without losing their balance to wash their legs? Things like that. We try to coordinate care with our music therapists, our art therapists, our child life specialists. So we're able to take our patients to a music therapy room or our Seacrest studio so that they're just getting to do normal things. And that makes them feel really good. We even have dog visits, which is so cool. And a therapy dog can come and visit our patients and they love that. One of the things that I do want to highlight for you guys is that we have automatic referrals for every oncology patient that comes into our unit. So we've worked really hard over the last 10 years to get to this place. And luckily, the literature and research out there supports therapy intervention for our patients. And so we've been able to really educate our oncologists, our nurse practitioners, our hospitalists, fellows, residents about why it's important. And one thing that I really want to highlight quickly for you guys is that even if a patient is inpatient for a short admission, it's important that we get our hands on them because we may have an opportunity to pick up something that they might not notice. We may see, I know they said that they are fine, but I think that their range of motion and their ankles are decreased. And that's an early sign to me of neuropathy. And so getting our hands on them time and time again, focusing on the changes over time, we know that they get diagnosed and they start treatment. You can have those acute treatment side effects, but you can also have those long-term treatment side effects, which can build up over time. So we're going to jump into 2 cases. This first one is about a sweet little 10-month-old female. And when she was 10 months old, her mom felt a mass in her abdomen when she was changing her diaper. She had had no fevers, no change in behavior or activity level. Her PO intake was the same. Her bowel and bladder habits hadn't changed. And so mom took her to the pediatrician. They sent her to the emergency room and they admitted her for further evaluation. When they did some imaging, they did an ultrasound, which revealed a mass in her right upper quadrant. They did a CT scan, which showed, again, a mass in her right upper quadrant, as well as some metastatic bone lesions in her right femur. And then they did a PET scan because there was a concern from the CT scan that there might be some metastatic disease. And they also found something in the chest with the PET scan. So her diagnosis was intermediate risk neuroblastoma. So there's that word again, where it's not really in the brain, it's in the adrenal glands. So some of the things that we noticed at the evaluation, and I want you to take special consideration to the ones that are bold and italicized. Some of the developmental skills that she presented with were her head control was great. She had no head lag. It was in a neutral position when she was sitting. Rolling, she could go supine to prone, but she had a really hard time with any other rolling, and she was very uncomfortable. In terms of transitions, she was emerging a sit to quadruped, but it required facilitation. And again, her fussiness was like off the charts. Prone, she could do all of the different positions, her arms extended, but oh my gosh, she was miserable. Super poor tolerance to being in prone. Sitting, she was independent, but again, super uncomfortable. Quadruped, she could attain that position independently, but didn't want to be in it. Crawling, she was scooting backwards and she was pivoting, but that was about the extent of it. And standing, she could stand while she was supported. So if you guys want to take a quick guess, I highlighted some of those things, and I wanted to see if you could use some critical thinking about and put together some of the things that we've talked about. Why were some of these, knowing her diagnosis, which was neuroblastoma, why might some of these things have caused her so much discomfort?
So feel free to use your raise hand feature, or you can put it in the chat to everybody, or you can put it to me privately if you don't feel comfortable putting it to everybody, and I will read it out loud.
Yeah, don't want to put anyone on the spot because I hate being put on the spot. But we know that for diagnosis, neuroblastoma originates in those adrenal glands. We know that she has a lot going on in her abdomen. So what are all of these positions kind of have in common?
Okay.
I got excited. I thought someone was going for it. All right. Well, I don't want to waste too much time.
Can I take a guess?
Yeah, do it.
Well, they require core strength and stability, I would say.
Mm-hmm.
And I was thinking maybe like neural tension involvement because of the neuroblastoma.
Mm-hmm. And we're also increasing that abdominal pressure. So it's uncomfortable. She was so much happier in the supine position or standing because nothing was being compressed. And so every time she was laying on her belly, it was putting direct pressure. She's sitting, we're increasing that abdominal pressure. Same thing with quadruped crawling. All of that was just putting a ton of tension on that belly area. So the really cool thing for her was once we started treatment and we were able to do a tumor debulking surgery, she started taking off developmentally because it no longer hurt, which is amazing. Just a preview for you guys. This is a list of drugs that she was on, this little 10-month-old. And you can see just some of the side effects that we can see. And so it's important for us to know she's getting this as a 10-month-old. We need to watch her over time. As she ages and grows, we may start to see changes in her cardiac function, her renal function, her hearing. So it's important to have an understanding that just because this is happening when she's 10 months old, it may carry with her. That damage can be permanent or semi-permanent. For her, mood changes, big thing. It was very hard to do therapy with her because she wanted mom and dad. That was the only thing that brought her comfort. But at the time of discharge, she was doing beautifully. We wanted her to do some early intervention afterwards so that they can continue to progress her developmental skills. Her mom and dad was super on board. Mom is mentioned in this discharge statement because she was the one that was there that day. But this patient is now a healthy, thriving, almost 3-year-old. She's developmentally appropriate, loves playing with her brother, and is doing fabulous. So there are some really wonderful things and miracles that happen in this line of work. So we'll go through this one super quickly, but I do want to emphasize with this one, I have some photos for you guys so that you can really see how a patient changes over time with intervention. So this is just a brief map of a patient who got a diagnosis at the age of 12, had multiple relapses, bone marrow transplants, had a stroke. This is just a little bit, a snippet of a medical history, 3 bone marrow transplants, GI, GVHD, like I said, a stroke, seizures, now has diabetes, went into cardiac arrest in the ICU, had multiple surgeries, has avascular necrosis of like literally every joint in his body, started to have some necrotic toes. We started losing toes over time. And I just think this is wild. So over this treatment span was really from age 12 to 19, where we were officially cancer free. And this patient got 771 doses of chemotherapy with 19 different chemo drugs, had 10 different radiation sessions. And then in terms of the total cost of cancer treatment from August 2015 to August 2021, excluding prescription drugs. Does anyone want to throw a ballpark out there?
Like 500,000?
8 million. Yeah. It's a lot of money. And that is just for his cancer care alone. So what I want you guys to see in the photos that I show you next, we're going to start this picture on the left. Is my patient after his first bone marrow transplant. He despised me during his first bone marrow transplant, which was very on par for his age. So there are no pictures of us during that point. But this is him coming back after his discharge, coming to clinic, getting a checkup. And you can see kind of some of those skin changes around his face. But for the most part, his hair's grown back, looks pretty good. In the next picture, you can see us working out, and this is after his relapse, and you can just like see right off the bat how small he is as a now 15, 16-year-old dude. No muscle mass, very thin. You can still see that change in his skin around his face, which was from some skin GVHD. And moving on to the next picture, this was just before his stroke. And you can see this still, the skin color changes, the darkening around the eyes, how thin he is. We don't have a lot of muscle mass, and he just looks sick. And I will say some of these images may be hard. Please feel free, if they're hard to look at, look away. But I do think it's important for you guys to see how treatment can impact these patients. These next pictures are after my patient had a stroke. He was intubated in the ICU, very, very sick, had a very difficult time even communicating. We worked so hard to rehab him. And finally, you can see on the right where we were right about the time of discharge after his 3rd bone marrow transplant and massive stroke. He did a lot of outpatient therapy, which is amazing. This was one of his visits with his service dog, Alex. And you can see even behind the mask, he's smiling, he's happy, he's looking a little bit fuller. And then we started dealing with some avascular necrosis. So this is actually after, the next two pictures are after a hip replacement. Imagine having a hip replacement at the age of 19. Like, that's crazy. After being discharged for quite some time, he came down with a respiratory illness. And this is how he came back in on the left. And you can just see how emaciated, how sick he looks. He had an oxygen requirement, but was still really doing well, all things considered. Things really escalated for him. And he went back to the ICU where he fluctuated between CPAP, BiPAP, nasal cannula, and really being depressed, overwhelmed, not wanting to move and function. He then and now is confined to a wheelchair. He actually has a trach, which you can kind of see if Chris's hands are right where I didn't want them to be in the last photo. But he is actually trached because his lungs have such fibrosis from all of the treatment that he's received. And he has lost a lot of teeth from his chemotherapy, his radiation. So eating is difficult for him, and he's in a wheelchair. And so you can see kind of that transition of over time, how even though he was cancer free he hasn't really had cancer treatment in about a year and a half, 2 years, we're still dealing with those late term and long-term side effects. So I hope that these pictures gave you a little bit of an idea of what your patients may look like. The last thing I want to show you is just some resources that are really helpful for you guys as therapists and patients. There are a million organizations out there that support our patients, that support our oncology therapists. And I would encourage you guys to take a look at some of these just to learn. One of the coolest things that they do, there's an organization called Monkey in My Chair. So for patients who are in the hospital and can't go to school, they literally take a life-size monkey stuffed animal and they put it in the patient's chair at school. And the classmates take pictures and all of that with the monkey, and they get sent to the patient in the hospital, and the patient has their own little mini monkey version. And it's just a great way to make the students remember and know that the patient is involved in there. So there's so many cool things out there. Thank you guys so much. I wish I literally had a million more days to talk to you, but I'm so glad that we were able to get through what we got through. This is my contact information. If you want to email my personal email or my work email, please feel free. Find me on Instagram, anything like that. I would love to talk to you guys more if you have specific questions.
So if you have any questions for Dr. Bernstein, and Jen, that was awesome. Please raise your hand. You can unmute and ask them, or you can put them in the chat or direct message me and I'll read them to her. Guy?
Yeah. So my question is, at what point is it safe to begin working with a patient with ongoing cancer? And if so, what kind of interventions would you recommend?
That's a really great question. So in the inpatient setting, we start from the day of diagnosis. So we are going in there, we are getting a baseline assessment, and we are setting up a plan of care. We are communicating with the nurses, the doctors, the medical team, and really just trying to make sure that the things that we are doing are promoting healthy routines, strengthening all of that. There are times where we have to take a step back when our patients are having increased nausea, vomiting. They may need to be getting a blood transfusion, and we might have to just say, all right, maybe today is not the day. Typically in the outpatient setting, you're going to get that referral from a physician when they feel like these patients are ready. In the outpatient setting, you do see a little bit more of like a prehab approach for patients. So sometimes they know they're going to have a massive surgery and they want to build those patients up prior to surgery. There may be a lapse in outpatient while they're having surgery. Hopefully they're getting intervention in the hospital itself. But typically physicians, they've seen what the literature shows and how much it encourages movement. They actually right now are recommending 150 minutes of activity a week for these patients. So it's a good amount. And it's, kind of this mild to moderate activity. So it's higher frequency, mild intensity, which obviously has to fluctuate based on where they are in treatment. But that's one of the important things about using your clinical judgment is you can kind of assess and modify for the patient wherever they are in their treatment routine. So maybe they do just need to walk, stretch, do really simple like body weight exercises. Or you may have a patient that's feeling great and you're able to really do higher level balance, strengthening with resistance. It just depends on their presentation, and their presentation will probably be different every time you see them. But taking that symptoms-based approach and looking at their kind of medical status will be a great way for you as a clinician to decide how to intervene and when.
Thank you.
Katrin?
Yeah, I would just like to add, like in my lifetime of outpatient therapy, I've seen a lot of those diagnoses. So sometimes they're in home, or sometimes they're coming into your clinic, and it's really important that you all educate yourselves about their blood values, and that you're communicating with the physician, because certainly in the hospital, I think there's a lot more backup and support for those daily decisions about whether the patient is capable of exercising. And when you're in outpatient therapy or in home care therapy, not as much support staff to help you.
Absolutely. And I really try, especially, it's a little bit harder for my pediatric patients, but my patients that are in that AYA range, and if you have adult patients, teach them how to advocate for themselves. A lot of my patients, their blood values get posted on their MyChart. Everything is digital these days. So not only do you have access to that, but if you're giving them a home program, teach them how to look at their blood values so that they can decide, this is the home program that I have to do today with resistance or whatever, or today I really have to just try to walk around the neighborhood. Give them that power. That is a huge part of oncology rehab in any age range, whether you're educating the parents, the patients, the children of your patients. They need to know how to advocate for themselves and take care of themselves.
Abby?
Yeah, I have like so many questions, but I'll start with for like your staff and like working with this population, what is like your one piece of advice that you have for dealing, I guess, with the mental or physical requirements with working with this population? And that's pediatric and oncology and all mixed together.
Yeah, that is probably one of my like most asked questions. And it's still something that surprises me, that I'm like, we're talking about oncology and I'm this excited. Like, it doesn't feel like it goes hand in hand, right? But one of the things that I have learned throughout this process of mine, which has been almost 10 years now working with this patient population, is there are really hard days, especially in the inpatient setting. You are spending so much time with these patients and their families. They trust you, they rely on you. You are there with them through their most vulnerable moments. And my first piece of advice is, it's okay to feel, and it's okay to cry and mourn what's happening to your patients. And the other thing that I really try to preach to myself is, no matter what the outcome is for these patients, we have made a difference in their life. And so I know that an intervention that I provided brought them happiness. It gave the family extra time. I was able to bring them outside so they could take family pictures. I was able to, set up a listening space for them with a music therapist so they could jam out one last time. And so really reminding myself that even though I didn't have a direct ability to save them, I helped make their time better.
I had a question about family support and everything, because I know it's more normal to have parents that are like, trying to support their kid, but how do you handle parents kind of butting heads with treatment and or not allowing the kid to have the treatment that the kid wants?
That's another really, really great question. And I think you come across this in any treatment setting that you're in where there is a family dynamic. So whether you're in acute care, whether you're in rehab, regardless, if there's family involvement, it can be really tricky. One of the things that I feel really lucky about in my institution is therapy has been integrated into the treatment protocol. So when our patients come in, they know that just like taking their medicine, participation in therapy is required. Now, you absolutely still have parents and patients who know that and don't care. And so, again, one of the things I really try to do is educate. And sometimes that's why it's really important for me to get a patient at the very beginning of their treatment and at the time of their diagnosis, even though it's overwhelming for them. It's my ability to kind of wrap my hands around a situation before they start getting chemo, before they start getting even more sick. So I've created that buy-in with the family and that trust. If I'm showing up first for the first time when their patient, their kid is already getting sick and wanting to sleep, the odds are they're going to push back and they're not going to want to participate. But if I've already established a routine, the most times the patients are really excited to come and they fight through those moments. But absolutely, you're always going to have a parent or, again, anybody in the care system who is going to fight back. And that's where I educate, I do the best that I can. And then I go back to that medical team who are my partners in all of this. And I talk to them about this is what I'm experiencing. And sometimes I have to toss it back to them to kind of say, what do you want me to do? If this patient or parent isn't ready to receive the intervention, we're going to pull back for a little while and then reassess. Or sometimes it takes the doctor talking to them and they are like, oh, it's what the doctor wants. That makes sense. So there's a lot of different approaches, but really relying on the team that you have is important. These are great questions, guys.
Brooke.
Do you tend to see like the same patients throughout their visit, or do they switch between different therapists?
So the way we have our caseload split up are we have different units within a floor. So I'm responsible for one part of the unit. My another therapist is responsible for another part of the unit. So we're each responsible for 24 beds. So it's our job to manage those 24 beds. So there are only so many patients I can see a day. I have to eat lunch. I like to go to the bathroom sometimes, those kind of things. So it's crazy to think that I'm going to be treating patients the entire I do 4 10-hour days. And so it's crazy to think that I can manage all 24 of those patients by myself throughout a week. So sometimes I'm reaching out to coworkers. We have specific coworkers that their job is to float throughout the hospital. So I might say, hey, I have 5 patients that I need help managing today. And I might pass them off. I try to be really aware of when my patients are discharging. So if I know they're going to leave on Thursday, maybe I'll see them on Monday and Wednesday so that I can get their treatment complete. And I know I'll have an open slot towards the end of the week. Every institution does it a little bit differently. But for me, I really try to manage my patients within my 40 hours of work, knowing that sometimes I end up seeing 14 patients a day. And sometimes it's a really bad day on the unit and I see 4. So it can be a lot of ups and downs with this patient population. It tends to be like Mondays and Fridays. I think Monday is like all of the ancillary services that weren't there on the weekends are like rushing in. And depending on when you get to the room, they're like, oh, leave me alone. And then on Fridays, everybody's exhausted because we've all been bothering them all week. So those are some days are hard, and rainy days are the worst because the rooms are dark and they don't want to get up and they just want to watch a movie. And so you have to get really creative.
Okay, if there are no more questions, like going once, going twice, I think that covers it for things I needed to say, but I would like to extend a thank you to you, Jen, for giving us your time on a Wednesday night. I thought it was really informative, and I'm so grateful that you were able to come to speak with us.
Anytime.